Hello everyone, welcome back to Rheuma Talks. If you have been referred to a rheumatologist, there is one blood test you have likely heard of, that is the ANA test. Okay, ANA is your anti-nuclear antibody test. Maybe yours came back positive and you're feeling anxious about it. Does it mean you have autoimmune disease? Does it mean your immune system is going to attack you? So today we are stripping away the medical jargon. We'll talk about what ANA actually is, how we test for it, and most importantly, when you should and you shouldn't worry about the results. So come, let's dive in. So what is ANA? ANA stands for anti-nuclear antibody, as I already mentioned. Normally, our antibodies are like a security team. They attack foreign invaders like your viruses, your bacteria, but sometimes the body produces autoantibodies that get confused and target the command center of your own cells, that is your nucleus or the cytoplasm. That's when you develop your anti-nuclear antibodies. Okay, for example, think of ANA test as a smoke alarm. It tells us that there might be some fire or inflammation in the body, but it doesn't always tell us where the fire is or even if it's a dangerous one. So how do we test for ANA? We have two methods of testing usually commonly done, that is your indirect immunofluorescence and your ELISA, which is your enzyme linked immunosorbent assay. So not all ANA tests are created equal. There are two main ways lab test for these antibodies. The first one I already mentioned, that is your IIF, which is your indirect immunofluorescence. This is the gold standard method of testing for ANA. Okay, so here we take your blood, put it on a special slide which has human cells, and then look it under a microscope. Okay, usually a epifluorescence microscope. If it glows, it's positive. This method is highly sensitive and allows us to see the patterns and also titers of your ANA. The next method we use is ELISA. This is an automated, faster method of testing for ANA. It's good for screening, but it sometimes can miss certain antibodies that we can detect using immunofluorescence. Okay, so as rheumatologists, we usually prefer indirect immunofluorescence method over the ELISA method. Okay, when we look through the microscope, the glow which we see isn't always the same. In fact, there are some 30 different international patterns that has proposed by your ICAP. Okay, so the common ones include your homogeneous pattern, which is often seen in SLE. Then we have speckled pattern, which is often seen in SLE, your mixed connective tissue disease, then Sjogren's disease. Then we have centromere pattern, which is frequently linked to scleroderma. Okay, then we have nucleolar pattern, which is also linked to systemic sclerosis. Okay, then we have cytoplasmic pattern, which is often linked to antisynthetase syndrome. Okay, then each pattern will give us a clue. It's like a fingerprint, okay, pointing us towards a specific diagnosis. However, a pattern alone isn't a diagnosis, it's just one piece of the puzzle. We need to correlate the pattern clinically, whether the patient is having symptoms and signs, and also certain other tests are also needed as an extra add-on over the ANA test. So ANA itself may not be diagnostic for a particular disease. So let's clear up some common myths. Does a positive ANA always mean that I am sick? No. The fact is, up to 15% of even perfectly healthy individuals can have a positive ANA. Okay, it can also be triggered by a recent viral infection, certain medications, or even vaccination also sometimes can trigger that your ANA positivity. Okay, the higher the ANA positivity, does it mean that more sicker you are? Absolutely no. The fact is, for example, a high titer like your 1:640 titer is more significant than a lower one, that I agree, but the number itself doesn't track how your disease is doing day by day. So don't chase the number with more and more medicines, and don't keep repeating your ANA test. So that is absolutely meaningless. Okay, so when should you actually get the test done? Okay, only if you have clinical symptoms, like for example you have inflammatory arthritis, okay, you have a butterfly shaped malar rash, or you have a dermatomyositis like skin rash for example, or photosensitivity you are having, then multi-system disease involvement is there which is unexplained by your routine tests. Then you are having Raynaud's phenomenon, you are having muscle weakness, you have Zika symptoms, that is your dry eyes or your dry mouth. So these are some of the common indications where we test for ANA. Testing without an indication often leads to unnecessary stress among the patients and also among the treating doctor also. Okay, so don't test ANA unless there is a proper clinical indication. Okay, if your ANA is positive, just don't panic. It's just a conversation starter with your rheumatologist, not a final verdict as such. Okay. If you found this helpful, please hit the like button and subscribe to Rheuma Talks for more clear-cut medical info. So until next time, stay healthy.